So this session is going to get much further into the weeds of the under 50 employer group range, and each of the panelists has a prepared PowerPoint. Here to start off this session is Sean Van Ness from Arise Health Plan.
All right, so what I'm going to talk about today is what PPACA health insurance market reforms are coming down the line in 2014. One of the major market reforms is guaranteed issue. Now, this already applies in the small group market, but it's new to the individual market. Basically what this is, insurers must sell a health insurance policy to anyone that applies for one, regardless of any pre-existing conditions. Insurers cannot exclude or limit coverage for a pre-existing condition. Wisconsin actually has its own program right now called HRSP. It's a health insurance risk sharing plan. That is the pool of individuals that are being declined for their conditions. That goes away next year. So December 31st, that goes away simply because those individuals now have the opportunity to get coverage in the private and public exchanges. Coverage reforms. Individuals and small groups must cover a package of benefits. They're called essential health benefits, or EHBs. Again, for the small group market, not a ton of changes here. Currently, most small group plans cover a lot of these categories. There are a few differences. For the most part, pediatric services, including oral and vision care, that's something typically not covered now. Habilitative services, that's also somewhat new. To give an example of that, let's say you have an injury to your leg, you go to therapy, so you're able to walk again. That's rehabilitative services. Habilitative is more something that you're born with, congenital. You never had that ability in the first place. Now those services are called to help you gain that skill. So that's EHBs. Modified community rating. This was touched on the last session. This is basically insurers in the individual and small group markets may only take certain criteria into account when rating their products. First one is whether you're an individual or a family. They also take into account the area of the state where you're located. Wisconsin is divided into 16 distinct rating regions, whereas in today's atmosphere, it's rated by zip code, the first 3 digits of the zip code. Also, age and tobacco use. Age was hit upon in the last meeting, but essentially the takeaway points there is now in today's environment, it's a 6-to-1 and 8-to-1 ratio. 2014 is 3-to-1, so the impact is the younger demographic rates go up, older goes down, and there's going to be some rate crunch there. Metal levels, also touched on the last one. Basically, each individual and small group plan will be categorized into the bronze, silver, gold, platinum. The 60%, which is the AAV, it actually doesn't have to be exactly 60%. What it is a plus or minus 2 actuarial value. So a bronze plan is going to be 58 to 62, silver is 68 to 72, and so on and so forth. The definition is the tiers represent the average portion of expected cost the plan will cover for an average population. What that really means is if you have a 60% plan for a bronze, that unique set of benefits, you can expect that on average 60% of your costs are going to be covered. Moving along with some other market reforms, out-of-pocket reforms, that is different. For 2014, all plans will limit in-network expenses to a $6,350 deductible for an individual or $12,700 for a family. It works a little bit different than today's world too. In today's world for out-of-pockets, it's typically deductible and coinsurance. In 2014, that includes copays. So any of your office visit copays, prescription drug copays, those all combine into one bucket for the in-network. Again, I just want to point out out-of-network services do not count toward these limits, so something you want to take into account if you're looking at a PPO or a point-of-service plan. Another note, for 2014, out-of-pocket expenses tied to prescription drugs will not count toward these out-of-pocket maximums if that prescription drug plan is separate from the medical plan and the insurer chooses to delay. I'm just going to clarify that. So if you have a medical carrier that uses an outside vendor, a PBM, pharmacy benefit manager, and they don't think they have the ability to coordinate the accumulators for medical and drug, They have the option for next year to delay that, and you might see out-of-pockets that are separate, so you could have more than that $63.50. For an example, with the Rise Health Plan, we also use an outside vendor, Express Scripts, but it's something that we chose to keep that one out-of-pocket between the medical and drug. We've been coordinating that out-of-pocket in real time for a number of years because we work with health savings accounts and high deductible health plans, so that's not an issue for us, but something to keep in mind when you're comparing coverages. Deductible reforms, generally for small groups, you can't have a plan that has a deductible more than $2,000 for an individual or $4,000 for a family. There are some ways to get over that if you're an employer and you're contributing to a health savings account or an FSA. You can bump up that deductible over that $2,000. This slide I'm going to gloss over. This is just stating that the Federal Exchange or the Marketplace is a website. It's healthcare.gov. This is where you're going to go there and you're going to check your eligibility for subsidies and so on. And stating the initial annual enrollment period for is the same for the Federal Exchange as the inside or outside. SHOP, Small Business Health Options Program. Again, federal website where you'll be able to get on and shop for your plans. To be eligible, the first year is 2 to 50 employees, full-time employees. A couple notes in the SHOP. Nothing requires you as an employer to purchase your coverage on the SHOP. Insurers are not required to sell on the SHOP. So you want to make sure that as an employer you should compare plans on and off. And also be aware that whether you buy on or off, the price is going to be the same for that set plan of benefits. So what's the SHOP going to look like this year? In reality, very similar to what it looks like now as far as how you buy your insurance. What I mean by that, it's really employer choice. So as an employer, you go on a SHOP, you pick your plan, and then you offer that plan to your employees. The intent and what was delayed, an important piece is the employee choice portion of it. That's where you as an employer would go in, you would pick a metal level, and then your employees would get on, and they would compare and purchase plans that are within that metal level from different carriers. So that was rather complex, and the government decided to delay that for a year. So I'm going to hand it off to the next.
Thank you, Sean. And now from a tax and accounting perspective, Terry?
The first thing I want to kind of just go over a little bit more in detail is this premium assistance credit. This is the subsidy for purchasing insurance on the exchange. And I spoke briefly in the first session about how it really applies and and I didn't really talk about how it was computed at all. But again, the 3 requirements that have to be met in order for a person to purchase their insurance or to get the subsidy is they have to purchase their insurance on the exchange. Their household income, which is really their adjusted gross income on the return with them and their spouse, and they pull in any kids who have to file a return. Their household income has to be between 100 and 400% of the federal poverty level. And then the third thing has to occur is that they have no employer-provided insurance or it is unaffordable to them. And unaffordable to determine whether or not you're eligible for a subsidy is based on looking at in single coverage. So even if that person is using family coverage, it's the cost of single coverage that the employee has to pay. You look at that premium and compare it to 9.5% of their household income. And if the premium is more, then they qualify for a subsidy. Now, the other requirement is, or the other way you can get a subsidy is if that your insurance does not cover at least 60%, this bronze level of value. And I think it's probably correct to say, Mike, that most insurance companies are not going to even offer plans that cover less.
Well, we're starting to see a lot of the carriers roll out their products for January 1, and all of them, at least to date, will be essential health benefit compliant. Yeah. And in some instances, you only will see, say, gold and silver level plans, and not even platinum and bronze in terms of selection.
So the requirement that your employer isn't offering adequate coverage is probably not going to be the way you get a subsidy, because that's all going to qualify. So it really becomes an affordability issue. And remember, while the total premium that your employer has to pay or that is being charged by the insurance company for insurance is set by the insurance company. The portion that the employer charges to the employee is set by the employer. So affordability is determined by the employer, so there might be a planning opportunity here. What is the purpose of the premium assistance credit? It's to help make the insurance more affordable. The premium, and it's a range. The credit is, it's based on your household income. It's not based on the premium. So to some extent, individuals don't care what the premium amount is because you pay a % of your household income. And at the lower end of the federal poverty level, you pay 2% of your household income. And at the 400% of the federal poverty level, you'll pay 9.5% of your household income. So it's based on household income amounts, not premium. Now, there is one caveat on that, is that the premium assistance credit is based on the silver level, that 70% coverage. So if you qualify for a subsidy because you go to the exchange, your income is between 100 and 400% of the federal poverty level, and your employer doesn't provide insurance or it's unaffordable, and you choose the platinum, your credit is only based on the silver level of coverage, so you will end up paying more than maybe what you're deciding to pay more at that point. The credit does not cover up to platinum coverage. Now, I do think it's really critical for small employers to understand this, because I do think at some point in time you may say to yourself, boy, I'm offering affordable insurance to my employees, and realistically, they might be better off on the exchange and have less expensive insurance. So what I did is I put two examples, or I have two examples here for a family of 4 and then single coverage, or a single person, in terms of what does this credit really mean to somebody, the subsidy. So I did 3 different examples, and I kind of tried to give it to the different ranges of where your employees might fall in the household income level, just so you can kind of see, hey, maybe I really have some decisions here to make for some of my employees. So in the first example, in a family of 4, income level of 4, or household income level of $40,000, that puts them at 171% of the federal poverty level. Based on the math and the way the math that was written in the law, they pay 4.95% of their household income as their share of the premium. That is $1,980 a year, or $165 a month. That's probably very affordable for them, and maybe less than what they're paying for insurance through you. And so if you will continue to offer insurance for your employee, which again is based on 9.5% of their household income compared to single coverage for the employee portion of single coverage, if you make your insurance affordable, even though they might pay less in the exchange with the subsidy, they don't get it because your insurance is affordable. The next example I have is a $60,000 household income taxpayer or employee. They're at 256% of the federal poverty level. They have to pay 8.23% of their household income. The maximum penalty or maximum premium they pay if they choose the silver level coverage is $4,938 or $412 a month. Maybe comparable to what their insurance is through their employer. And at the opposite end of the spectrum, you have the $90,000 household income employee. They're at 384% of the federal poverty level, so still eligible for a subsidy because they're not over 400%, but they are paying the maximum amount on their own at 9.5%. Their maximum annual premium is $8,550 or $700 a month. If you terminate their insurance, they might be very unhappy with you as an employer, and you might need to give them some kind of increase in pay. And so somewhere along the line, whether it happens this year, I think is probably early because there's probably not a lot of information to make this decision at this point. But in some point in time, small employers will be going through this process, I think, to determine whether or not I should continue to offer coverage because it might harming or hurting my employees. And as some of the premium rate increases kick in 14 because of the community rating, it might be just out of economic benefit you have to go through this process just so your company survives. I mean, depending upon what your situation is. I also did a single example, but I'm not going to go over that. So understanding that is really important. It's also important for everybody in the room to understand this because we're all individuals. And we might qualify for the premium assistance credit. So in terms of, so when you're looking at like the range of the $40,000 employee to the 60 to the 90,000, let's just say those are your two groups. So I'm going to have people jump in here too, but right now you can discriminate. For fully insured plans, you can discriminate. in terms of, now I don't think you can from an underwriting perspective. I mean, you can't pick and choose people who are healthy or not. But from an income tax perspective, there is no taxability issues in terms of you can decide who you want to offer insurance to and who you don't. So yes, you could possibly say, or here's what you do is to the $40,000 employees, you raise the cost that you're charging for the employee portion of single coverage, you raise it to make it unaffordable for some of those people. You raise it.
I think I can add something to that as well. So yeah, Terry is absolutely correct that right now there is no prohibition under the Affordable Care Act rules that is in effect and that is being enforced, I should say,
Right.
against kind of discriminating on who's eligible under your plan. Now, when the statute first came out, everyone was shocked by a provision that said those what we call non-discrimination rules would apply, and you would not be able to basically give more highly compensated employees a better benefit than lower compensated employees are entitled to. It's always been allowed to do that in the insured plan market, so this was a big change. And my experience is no one has the first clue of how to implement that change. It's just been so standard. So the IRS sort of pulled back and said, whoa, okay, given all of the commentary we've received and all of the pushback from all the stakeholders, we're not enforcing that. I think they're going to be rewriting some rules considerably, and we just need to wait and see what happens. There may be future rules. It's a low priority for them, but for now it's absolutely fine to pick who is eligible or not, including if part of that decision is your strategic choice to pay a penalty for a few select people, if that might be cheaper for you overall.
Right. Yeah, so long and short of it is there's no discrimination issues right now for fully insured plans. That is in the law, but they have not acted upon it. There's no effective date on that, and so right now the sky's the limit on that. How much time do I have left?
If I could just add to
Mike.
that, and maybe Sean could chime in, as we are getting a little bit weedier in terms of some of the questions that we have. One of the issues that's still outstanding is, while we talk about guaranteed issue, and if indeed we have the opportunity to take a look at our workforce and try and decide what's best for the workforce and for the employer in terms of maybe a certain portion of our workforce is better off in the individual exchange because of the subsidies that are available. And as from an employer perspective, I'm still able to meet my recruitment and retention needs. One of the issues that we're faced with right now is what about things like minimum participation rules? You know, right now, you might recall that there's minimum participation rules and minimum contribution rules, and it would appear, at least again what we're starting to see from some of the carriers as they lay out their products for January 1st, and no prices associated with it, but the products. One of the things that we've heard mentioned is that while in 2014 this may be guaranteed issue, upon renewal in 2015 there may be the imposition of minimum participation and minimum contribution rules on the plans, both within the shop exchange and also in the private marketplace. And maybe Sean can elaborate a little bit on this. So we've gotten some conflicting messages on what 2015 will look like as it relates to that topic. You're not missing anything. I think the issue is going to be then the rules that should apply for participation is it's not, right now you might have 70% or 75% participation rules. So when the insurance company is looking at your group, they're looking at, say, let's use 40, 20 are gone, those are not counted, they're waived. And instead, as long as you have 19 out of the 20 remaining taking insurance, or 18 or 16, 17, whatever the number is, that's okay. And that's an area we're trying to seek some clarification, where as we get into this coming enrollment season, that's one of the we don't have that locked down yet. Sean?
I can confirm that the participation rate is still 70%, so it is that same percentage.
So what does that mean, participation, that they will not provide you with coverage if you do not have enough participation?
Well, I actually believe that is, and I would need to confirm this, but I believe last I heard is that they're waiving that requirement during the open enrollment period.
Are you talking just about the shop exchange, or is this is for private, this is just for?
I'm talking about shop.
The shop exchange, the shop exchange, okay,
Right.
so if you do not go through the shop exchange and you come to Mike for insurance, he doesn't really care how many people are participating.
That's correct.
Through the individual.
Exchange, as long as of the 20 that remain.
Well,
we're gonna meet
absent
whatever
the exchange,
participation-
though, absent the exchange, I mean, if he comes to you for insurance through Johnson and it's not through the exchange, and he wants to offer group insurance just through other
Well,
products.
there's still participation.
There is,
So
okay.
the expectation is that a certain percentage of the.
Okay, and that, so
workforce
if
in
you're
that.
saying if you do some of this planning and exclude some people, you might not hit some participation. And then no insurance company may insure
That's
you.
right, and that's what it's just counterintuitive, because right now you're talking about guaranteed issue and guaranteed renewability, then why are there
I gotcha.
participation rules? And I think, just to the point that Kelly made a little bit earlier about the non-discrimination rules, it's that one of those areas where I think over the course of the next year or so, we need some additional clarification and consistency.
So check with your insurer to see if they're okay with your plan.
Yeah.
Yeah, so his question is that, well, and what you're quoting is for purposes of the large employer penalty. Large employers have to offer coverage to full-time employees and their dependents. You guys, as small employers, do not have that requirement. You can do what you want. And so the premium assistance credit is based on single coverage, and your kind of question is well, what if I am a taxpayer who has a spouse and kids, and I don't have an employer that offers insurance to my spouse and kids, but they will cover me? And how does that affect that? Yeah, I don't really know the answer to that right now. That's a little bit of a complicated area, I think. But if you give me your card, I'll try to get back to you on that. Okay, I just want to keep moving here. Okay, a couple of things. Small employer health insurance credit. How many of you have been taking that in the past? It's somewhat limited because the dollar amounts are relatively small. But major changes starting for 2014. The small employer health insurance credit was one of the things that first came into law as part of the Affordable Care Act in 2010. But in 2013, there are two major changes to this. One, the credit goes from 35% of the premium that the employer pays up to 50%. So that's a great change. The second one is not necessarily that good of a change, is that in order to qualify for this credit now, you as the employer must get your group insurance through the shop exchange. So that would require a change in your insurance, I think in most cases, right guys? I mean, right?
Yeah,
You're going to have to change your insurance through the shop exchange. And once you do that and you claim the credit, that first year you claim the credit starts your first of 2 years in order to take the credit. So let's just say in 2015 you are eligible for this credit and you go to the shop exchange and you purchase your group insurance. You get 2 consecutive years from 2015 in which to claim this credit. So it's very limited for some reason. I don't know why they limited this, but they completely put the limit on this in terms of who's going to be eligible for this. And so if the first time you go to the exchange is 2020, that's when your 2 years starts. So major changes for that. So don't assume you're going to get that credit. Who really is impacted by this is very small nonprofits. This is where they're going to be really hit by this because they're taking this credit a lot. I just want to touch on some non-healthcare related things because there's equally some good news on the tax side of things too. The one thing that has been a huge planning opportunity is going to be a sore spot for a lot of my clients and probably for a bunch of you in the room is this 3.8% Medicare tax on net investment income. Things like interest, dividends, capital gains are all going to be subject to a new Medicare tax if your adjusted gross income as a taxpayer, so you and your spouse, if you have one, is more than $250,000. Now, the one thing I want to point out here is this is a very bad provision for a lot of my clients who own a company and then they own the real estate outside the company and they're paying rent to themselves. That rent income is net investment income most likely to you. And so while you move the rent deduction from your corporation to your personal tax return as income, and that washes out from an income tax perspective, moving that money from one pocket in the same pair of pants is going to cost you 3.8% Medicare tax. The IRS has got proposed regs on this. We're hoping that when the final regs come out, they maybe make a change to that to allow people like you to avoid this, but we don't think that's going to happen. So that's a horrible situation if that's the case for you. The other thing is, if you have shareholders in your S corporation or partnership that do not participate, let's say you have a family-owned business and you have some straggler brothers and sisters or something that own the business but do not participate, they are subject to this 3.8% tax on their passive income. You that participate, you're good though, no tax on that. And then we talked about the individual mandate. That kicks in 2014. Probably not a major concern for a lot of people in this room, but it could be for your kids potentially, depending upon how old they are. So that's all I have.
Thanks, Terry. So we'll get into the legal aspects of things. Kelly?
So I just want to continue with the theme I kind of started in the larger group session and talk about some just general benefits and legal compliance issues that maybe aren't always top of mind when you're thinking about the Affordable Care Act. So the first, there we go. Yeah, as I had kind of mentioned or alluded to previously, the fine art of employee benefits, of being an employer who provides what we consider a benefit, be it a health plan, a retirement plan, to your employees, you have to understand that those are very highly regulated programs. And the reason for that regulation is that there are tax-favored treatments accorded to the benefits. Under the health plans, what an employee receives from the employer in terms of health coverage is 100% tax-free to the employee. That's basically a form of wages being paid to the employee on which the government is not collecting a single penny. So, because of that, there are a lot of IRS and other hoops to jump through to make sure that you can continue to claim that tax status and that the employee can. I just have a few logos here to kind of point out some of the many players that are involved in regulating benefits, and I just have the symbols for the Equal Employment Opportunity Commission. They are in charge of administering, among other things, the Americans with Disabilities Act. That actually needs to be taken into consideration when you're looking at your wellness plan. I have the IRS, that's always a big player. The Health and Human Services Department, which plays a big role in administering HIPAA, in addition to the Affordable Care Act. They're also involved heavily with wellness program requirements. The Department of Labor, which is about protecting the employees' rights to receive what an employer promises them. And then we have the state of Wisconsin, because obviously there's all of the insurance rules that we're talking about today are state-based. Those rules are made locally in terms of the Affordable Care Act. Sometimes they're preempted by ERISA when we're talking about larger health plan requirements, but the state rules definitely play a big role. Another just general consideration is, why should an employer continue to offer or start offering a benefits plan in the first place? I had mentioned earlier that I really believe the norms for what is offered or not in terms of a health insurance plan to employees are going to be evolving by industry. I think it's going to be common or continue to be common, basically, that in certain sectors, health plans are not offered. And so in the new era, we're going to see a lot of those types of employees, relying on the exchange to get their insurance. We know that if you have 50 or fewer full-time plus full-time equivalent employees, you are exempt from the player pay requirements. I just want to add, during the break, Terry and I spoke with a gentleman who technically meets the definition of being a large employer of over 50, because if you add up all of his part-timers, he's over 50. But if you look at the individual employees, he only has a very small handful that actually work more than 30 hours a week. Everyone else is at, say, 28 or under. And he was very relieved to find out that When you're counting up to see if you are a large employer, you do count the part-timers, but when you're looking at penalties that you owe, you don't. So he was under the understanding he was subject to penalties and was happy with the news that he doesn't. So yeah, keep in mind, small employers are exempt from that, but there can be some nuances. And again, we had talked about having to aggregate if you have multiple locations or businesses under common control. You may think you're a small employer, but actually under the law be a large employer. In any event, if, you know, the classic reasons for offering benefits at all, if it makes sense in your sector, are that you can help recruit people. Obviously, if you can allow people access to insurance and it's on reasonable terms, that's going to help you be competitive in your marketplace. It can also maybe keep that employee from leaving and going down the street to maybe an employer that doesn't offer it. But one of the number one considerations for employers to offer it is it's a tax-favored benefit. I had mentioned that employees do not pay any tax on the value of health premiums paid by the employer, but the employer gets to deduct everything that they pay in the way of premiums. So it's a really cost-efficient way to compensate your employees. Remember, benefits are a form of compensation. So if you're paying an employee either $1 through the normal way, that dollar gets, minimized because the FICA tax comes out for both the employee and for you as the employer. But if you're paying, you can provide the same dollar in the form of a health insurance premium, and you get to deduct that, and you don't pay the extra FICA amount. So, traditionally we see that employees are often, probably more than willing to trade $100 in wages for $100 in a health insurance benefit. It's just, it's a nice way to receive compensation for all parties, or to pay it. Terry talked about the tax credits. The small employer tax credit will still be available if you qualify for that, and if, starting in 2014, you get your coverage through the shop. So another potential tax benefit that might apply depending on your business. Now here's a slide, I called it Benefit Options and Flexibility. I get so many questions from employers about, they're the what if questions and the can I questions. What if I offer an HRA? Can I, similar to a question someone asked already, can I carve out the spouses and the kids? I'm going to follow up to that question that was asked and point out that under state of Wisconsin rules, completely separate from Affordable Care Act, if you are offering an insured plan, you have to at least offer that coverage. Actually, the insurer is required to offer it to the dependents and the spouses of any employee who works 30 or more hours a week. Under Affordable Care Act, there's a rule that you can't charge any more for the children up to age 26 than you charge for employees. However, there's nothing that would prohibit you from requiring a spouse to pay more than your employee does, either under Wisconsin or federal law. So you can kind of play with the costs with respect to spouses, not kids, if you have an insured plan, and the child rule would apply generally anyway. I'm trying to think of what's the most efficient thing to discuss in the short amount of time left for my opening comments, and then of course we're all open to questions. I guess I just want to point out, I mentioned on here FSAs, flexible spending accounts, health reimbursement accounts, health savings accounts. Just keep in mind as you're evaluating your programs, all of those kinds of things may or may not, depending on all of the details, affect the affordability and or minimum value of a plan that you may offer. If you currently offer a health reimbursement account that is not tied to your health plan, if it's what we call a standalone plan, maybe you don't offer health insurance, but you're just putting money in for employees into an HRA for them to use to reimburse some expenses. Unless that is only for retirees, you won't be able to have that in 2014. It's not going to be meeting the the limits or the lack of limits on annual dollar amounts and benefits. They're just going to be phased out. And I'm going to wrap it up, but I put a couple of items. Just be aware, some of the Affordable Care Act rules will still apply to you even if you don't offer any insurance. We had talked about the October 1 notice being one of those. I think I'm just going to end with that and say that we've all talked about the notice a lot. I recommend, if you haven't sent yours out yet, consider doing a cover letter to send with it, because you're in one of two situations, or maybe there are more options, but let's say you offer coverage now, and now you're just sending out this notice that talks about, hey, you can go to the exchange, because that's really what the notice says. That's going to create a lot of confusion without some kind of gloss from you saying, we're required by law to give you this notice, and if it's accurate, you might say, we think, we anticipate most employees currently receiving coverage here will certainly continue to do so. Ask us if you have questions about this notice. Or maybe you don't offer any insurance. There may be some other gloss you want to put on it. I don't want to use up anyone else's time or take away from question time, and I did already talk about wellness, which was one of my slides. I was going to end up on some potential tax penalties, and you probably won't be too upset if I save that. But again, any questions, just let me know.
Can I ask a question about the notice? And I want Mike or Sean to answer this. Okay, so here's my concern on this notice. This notice of the exchange has to go out by employers to give to their employees. And Kelly suggested, and I agree, is that if you just give this notice as is to your employees, they're going to be like, oh my goodness, what is this? What are you doing to us and whatever? And so there either should be some kind of meeting or a cover letter. My question is this, really, to anybody who wants to answer this, is that, okay, so now the employees have this notice, and now they're like, oh, I'm going to go to the exchange and start looking at this. Now they come to the employer and say, hey, this is what I can buy on the exchange. This is what our insurance has. Can you compare this for me? And who's going to help employees figure this out? Is it really the owners of the companies? Is it the HR people? Is it Mike, the broker? Who is the person that's going to help the people decide what's the best? Because right now, when we have group insurance, we have HR people, or the insurance company is providing information to our employees to say, here's the kind of options, here's how you evaluate it. But if they're comparing the exchange to their employer coverage, who's the person?
I'll take a first shot at it, and then this may be more for the insurance experts. But I know that, so the notice has actually two parts. There's a part A, which is actually the only legally required part that has to be given by October 1st. And you can use the model notice, or you can kind of draft your own if it contains basically all the same informational elements. Then there's a part B that, if you do provide coverage, specifies some detail about the coverage you offer, and it's even, if you provide coverage, it's individualized to employees. So there's a part B, and there's a section to fill in about, this is the type of coverage we offer to these types of employees at this price. And then there's a section, you are or are not eligible. But it will give them, I think, some kind of something to compare to the exchange on an apples-to-apples basis. I think that's the point.
But especially pricing, to me, there's a lot more that goes along with it. Like, what's covered? How much will I really have to pay? Like, who's going to be the expert on providing that guidance?
I don't believe they sent it out to the employers. I believe that back in, I want to say maybe, I don't know, it was spring, they posted a technical guidance.
That was May the 8th, 2013.
Okay, yes, that sounds exactly right. So that was an online guidance for employers, and it's pretty common that that kind of informal guidance is being used to disseminate information, and it had links to the model forms that they drafted.
Right. But the point first.
Oh, well, nothing goes to the DOL. It's just information. Like I said, the only legally required part is a one-page description that there is coverage available at the marketplace. You're supposed to give it to employees by October 1. They came out, I think it was Wednesday, and said, but if you don't, there is no penalty for it. So You know, that's a different philosophical question. A law without a penalty, is it a law? You know, that's a different discussion. I don't know if we need to go there.
Did you want to weigh in on that, Mike, or do you want to start? Okay, next up is Mike Derdzinski from Johnson Insurance.
While Mike walks up there, I just want to respond to Terry's question too on who's responsible for going over the differences between the group plan and what's available on the exchange. I think to be effective, it's really going to have to be a team effort. I think brokers are going to play a huge responsibility because they're aware of the group market and the individual, the company itself and insurance companies. And there's going to have to be some responsibility on individuals too to know what's out there. So again, I think it's going to be a combination of all those components.
Yeah, that's a good point, Sean. I've sat on a panel with Kelly and Terry, actually all three of us in one panel, and with Terry and a couple others. And one of the things we always talk about, because of the complexity of the law and how it touches so many elements of our lives, that from an employer perspective, really having a strong team that's represented by the panelists is absolutely essential, because it's your agent or broker, it's your attorney, it's your CPA, and then your carrier partner and your healthcare providers in your community. That's really the team that will allow you to hopefully do what's in the best interest of yourself as an employer and as an individual and your family. But it's a really good question. The last couple slides that I want to share, just to talk a little bit about how do we go about controlling costs, because as I think what Steve mentioned at the beginning of the session this morning, when it's all said and done, we are concerned about healthcare costs. And if you look at the GDP, 18% of our economy goes to healthcare. So that's 18 cents out of every, I'm a simple guy, so 18 cents out of every dollar that's out there is going to healthcare. And somehow or another that has to help make us more productive and a better country, so that as we go out and we do our jobs and we compete in a global economy, we can be successful at it. So what can we do to slow down that rate of increase in terms of the percentage of our economy that's devoted to healthcare? What can we do as individual employers? Some of the things some of the opportunities that are presented by the Affordable Care Act have to do with taking a look at self-insurance. We mentioned that briefly this morning. When you think about the impact of community rating on a group, again, if the average age of your group is 61, a fully insured plan under community rating, it's going to be probably a pretty good deal for you. On the other hand, if you're, a dozen 30-year-olds, it may not be a very good deal. And instead, you might want to think about self-funding. And self-funding has, there's traditional, real solid reasons why we self-insure. You avoid certain taxes and mandated benefits, and gives you a little bit more control over your benefit design, and also controlling the cash flow that you have as an employer. But there are some significant risks, and obviously the most important one is the assumption of that risk in case you have one or two instances of very sick people in the plan. And then, of course, there are some increased administrative tasks associated with a health plan, a self-funded plan. But when it's all said and done, in this new environment, we have a fail-safe that was mentioned. Because let's just say, for example, that you are an employer that has the average age of 30. You go self-funded. You've got really great rates. Maybe you're doing a lot of wellness initiatives. Everyone's really active and engaged and taking good care of themselves. But you do have, a bad accident, a motorcycle accident, and it's fairly expensive, and it means your stop loss is going to go up significantly, and so you're going to have much higher rates. There is a fail-safe, at least right now, and that is you can move into the shop exchange. The only problem I always have with when I describe a scenario like that, because it sounds pretty good, doesn't it? If we're a healthy group for whatever reason, we can go self-funded, take advantage of hopefully better financial performance, and then when things get bad, I can jump into this marketplace and still be taken care of. Whenever there's something that sounds too good to be true, there's usually going to be a catch. And I will tell you right now, 2 states, California and Utah, which are running their own exchanges, they're actually actively looking to prevent that from happening. So while with the federal marketplaces, there's no indication of that, depending upon what happens in California and Utah, just something to be aware of going forward. There's a few more specifics associated with self-funding in terms of there's fees associated with PCORI. We haven't really talked about PCORI all that much, but if you do go self-funding, you will help pay for the Patient-Centered Outcomes Research Institute. And that long-winded name is really, PCORI is really short for how do we aggregate all the best practices in healthcare and then distribute them to the population as a whole so we can accelerate improving healthcare delivery in our country. And then the other one has to do with the premium stabilization or reinsurance fee, and that's about $63 a head going forward, but it's supposed to conclude at 2016. But at any rate, self-funding is definitely an area that people will be looking at as we move forward. The other thing that we talked about briefly is early renewals. And we talked about what could you do when you go home today or go back to the office. You might want to take a look at, if you haven't already made the decision to consider early renewal, to do so. Because as we've seen all along, come January 1, with the different metallic levels and the inclusion of essential health benefits, community rating, we will see an increase in rates. And if folks want to have the opportunity to have a window to wait and see what's going to happen, early renewals is one way to make that happen. So if you haven't considered it, definitely you may want to consider it for all the reasons that I just outlined here, as far as what's happening with community rating, the inclusion of essential health benefits, and what have you, because it is going to result in significant increase in costs. And I think the rest of this just kind of defines all those terms, which more than happy in the interest of time, because really what we want to do is engage you in your questions. I'll turn it over to Dan.
I don't know if there's a simple answer to that question, but the 84% of the companies that have less than 50 employees feel your pain. And I guess it's trying to add 24 more hours to your day and finding good advisors. Yeah.
Yeah, I don't really know what to say to that. I mean, I have clients that are large, I have clients that are small, and we got together as a group in our office, and with some of our smaller clients are like, if we hand these notices out to our employees, our clients, and say, hey, give these to the employees, they're going to get a million questions, and so we're trying to head that off at the pass. But, I mean, one thing, someone threw it out in the audience, I mean, there are navigators and assisters, and maybe Sean and Mike want to talk about that a little bit more in terms of who these people are to provide assistance for those who are applying on the exchange. There is some guidance put into the system. I think the piece that might be missing, and they should talk about this when I stop here, but the piece that might be missing is, okay, well, they can get information about the exchange and the product, but who kind of pulls it together for the employee and says, well, when I compare my insurance for the employer to the exchange, yeah, I don't know who that person is. That's new business that opens up, new consultants that hopefully are only at $70 an hour, not $250,
Yeah, I just want to jump in and on the subject of new consultants and providers, I am seeing a lot of activity of certain old and new companies stepping in to try to help employers manage some of the administrative parts of this, whether it's counting and tracking employees and how that changes over time, or I'm sure there are any number of other services that are going to be evolving. I attended a program yesterday that was sort of by and for employee benefits attorneys talking to one another, and we've got better experts here than me, certainly, but I learned that we were talking about the role of the employer as a health plan administrator, which has been our traditional paradigm, and how that changes if an employer is providing the plan or the insurance through a shop, through the small business part of the marketplace. I think a lot of the administrative functions are going to be shifted to the shop because, for example, one of the traditional roles of the employer was, well, you provide a summary of the benefits. It's going to be pretty tough to provide a summary of benefits once employees are allowed. If an employer wants to provide insurance through a shop, eventually the employer can set a level and what they're willing to contribute and not more. The employees can go pick any plan that fits up to that. The employer is not going to be able to summarize all of that for all of the employees. That's going to necessarily go to the shop because they know what the employees are getting. So my feeling is that a lot of the work of this is going to be going to the shop for small employers if you choose to provide a plan that way. And then navigators are a part of the shop. They should help employees. And also, small employers, all employers should be expecting, you're going to be getting notices from the HHS throughout the year asking to confirm some details about an employee, like confirm that they are not eligible for a plan, confirm that their wage is X. So that's kind of an aside, but.
I guess I'll just, because I do think you hit on probably one of the most critical issues, and it's not going to go away for a while, because as with any massive new undertaking, such as trying to cover every American in one way or another, there are going to be significant bumps along the way, and quite frankly, a stretching of a lot of resources to get it done. And so if we're looking at, talking about early renewals, one of the reasons a number of employers are doing early renewals was just to put off that very issue you're talking about, sir, so that see what happens over the course of the year and see if things don't start to develop a new normal that's easier to administer. So that's one comment. The other is, and I mentioned in the global session, there are going to be these regional enrollment networks formed around the state of Wisconsin that are going to have a lot of different entities involved, trying to come up with a way to provide resources out in the community. So for example, it hasn't happened yet, but talking about doing things where there are at a technical college where people are allowed to come in and have presentations and have their questions answered and essentially be open community forums and have representatives from the healthcare systems, have representatives from some of the advocacy groups, so that there's a great opportunity to have their questions answered and be plugged into the ability to actually enroll while they're there, if indeed they're going to enroll as individuals or as small employers. The frustrating part, I think, for all of us is that it's September 13th, and January 1 is just around the corner, and we're now starting to get organized. But I do feel it will be organized. It will address the issues that you're talking about, but it's going to be problematic in the short term.
There's a question back there. When individuals are looking to purchase the exchange, where do the employers tell the individuals to go?
There are a lot, and I think we'll have different responses, and again, some folks in the audience might want to also weigh in. But healthcare.gov, if you're comfortable with online experiences, it is a robust website that's been produced by the federal government. They send out notices almost daily now about where they're at with the federal marketplaces, and that's one vehicle. If you happen to have a agent or broker who deals with individual insurance, they can be referred to that particular agent who does individual health policies, and they'll be able to help. Because the nice thing about it, another term that you'll hear a lot of is called no wrong door. The idea is everyone in the country is going to get covered one way or the other. So it doesn't matter how you're going to access coverage, whether it's through the private market, it's through the federal marketplace, through navigators, certified application counselors, agents and brokers. There's going to be a vast array of individuals who will be able to funnel you to the right place to get coverage. In terms of major carriers that are not on the federal marketplace in Wisconsin at this time, it would be, for our marketplace, it would be United Healthcare, Humana, and then if you're talking about the shop exchange, the small employer exchange, also Anthem.
How do we make our employees feel comfortable that we're not just dumping them somewhere?
Well, I mean, I think if you look at the coverage and with essential health benefits, you can show them that the coverage is, better what they likely have today. One of the differences that you need to look at is there's a lot of more narrow network plans in the market on the exchange. So there'll be some exclusive HMO products, but I don't know if I'm completely answering your question, but I don't think you're going to see many differences as far as waiting in line or those types of questions.
Here's my comment on that. You don't need to do anything different. If insurance is really important to you as an employer and it's very important to you as your employees, you don't need to do anything different. You don't need to push anybody to the exchange. Keep your insurance, make it affordable, make really good pricing for them. You don't need to do anything different. You don't need to go to the exchange as an employer to purchase your group insurance. Wherever you are right now for your group insurance, that's still an option for you. I mean, you might have to just suck up the pricing, and whatever happens in 14 with the pricing and the community rating, you might have to just figure out how to eat that cost or pass it on to your employees. You don't need to do anything different, though. You don't need to push anybody to the exchange. You can continue on. I mean, a lot of employers are going to do that. Yes, correct.
Do they go, if they go to the exchange, do they lose the employer contribution?
And the subsidy makes up, the federal government becomes the employer to some extent. It pays the employer portion. Actually, taxpayers pay it. Sometimes the employer will pay more, sometimes the subsidy will be more. It depends. It really depends. Yeah.
Where do you find the healthcare application on healthcare.gov?
This is sort of when I wish we could be more interactive, but they have had different iterations. You might recall when it first came out, it was like 21, 22 pages long, and then they've shortened it considerably. Somewhere on the left-hand side of the column,
Oh, it is. It's there, though.
yeah, there is
Here.
one. There is one there. I haven't looked at it in the last month or so,
Yeah.
but you
Oh.
can
Is there?
access an
It's
application.
short.
In fact, they want you to, if you go onto the site now, and I did just go not a few days ago. If you go on the site, they actually do talk about on the home screen. You have to hit a few things if you want to start the process of filling out your application. So again, if you haven't had a chance to go on there lately, you might want to go on there when you go back to the office today and plug on, because at least earlier this week, the home screen actually had a few shots to get you started in the process in anticipation of October 1st.
The first one that I had, or?
No,
No,
it's like 10 tops.
It's smaller now.
It's short.
I think another good source for you to take a look at is regtap.com, REGTAP. It's open to the public. It's meant for CMS to communicate with insurers, but there's some really good information on there that's a little bit easier to find than healthcare.gov. So I would definitely check that out. It's regtap.com. It's REGTAP. You have to create an account, but it's not solely for insurers.
We have a question in the back. High deductible plan.
Yeah, okay. So here you have a high deductible health plan now with an HRA, and you want to switch to an HSA.
No, I want to know what happens to our plan now, because I'm seeing in one of your slides, no more HRA.
Oh, okay. Yeah, no more standalone HRA, that's right. So basically, I guess the question to ask is, how does a person get access to that HRA contribution? Is it by participating in your health plan?
Yes.
Okay, so that is what we would call an integrated HRA, and that is still allowed. That you can keep that.
Does our deductible then get lowered to the 2,000?
I believe that's a rule that applies across the board to everyone. That's, that's one of the insurance type rules, separate from the HRA rules. So, Well, to the extent that there are deductible limits, your question might be going a little bit to, if I understand correctly, whether an employer contribution to an HRA or an HSA affects the affordability and minimum value, because that is something that there's been some guidance on, and my understanding is that employer contributions do affect minimum value. So, and correct me if I'm wrong, but I interpret that to mean if the employer puts money in, you have a more valuable plan than if the employer didn't. So I think it can help that. With the HRA, it affects affordability. They look at it in terms of affordability. It only affects, the HRA only affects minimum value if the HRA can only be used to reduce their cost sharing. And we're getting a little bit beyond my expertise when we talk about deductibles and limits, but those are the considerations you might want to probe a little further.
Sean, do you maybe want to talk about your product array that you anticipate and its ability to handle the kinds of plan designs that we're talking about?
Yeah, I mean, there's not a lot of differential between products because CMS is pretty strict in what you can and cannot have, and we talked about the out-of-pockets and the deductible levels. We came up, and I can only speak for Arise of what we came up with our product design, but for individual and shop, we've offered all metal levels, platinum, gold, silver, bronze. We try to hit, what we see currently in the marketplace with our current business, and try to hit all of the different areas that we can actuarially justify for the new 2014 atmosphere. But yeah, there are those strict criteria that you have to follow for a small group as far as deductible, $2,000 or $4,000. But if the insurance plan offers, now I'm just speaking for the shop, a plan above $2,000, we have to actuarially justify it with the employer contribution to the HSA. So you can have that higher deductible HSA and still have the plan on the shop in certain situations.
But not the HRA.
No, that works too, doesn't it? Yeah.
Yep.
Yeah.
That's okay. I mean, you can have, right, like.
The integrated,
Yeah, you
the integrated
yeah, so, yeah.
HRA. It's a standalone that's considered its own self-funded plan, and
Right.
it has different rules attached to it. The other thing that the piece that still has to be layered on top of the different plan designs is the maximum out of pocket. That's $6,350 for a single, the $12,700 for a family. That's sort of the overall cap that exists across the board, and that sort of serves as the upper limit that any person is going to encounter in terms of out-of-pocket costs.
Connie, you had a question.
That was me.
Are you required to offer a group health plan? Or if you have a group health plan, are you required to offer spouse and dependent insurance?
So my question is, how is that a state law or a national law? Because how was UPS able to drop coverage for spouses?
Yeah, I saw that in the news. There are a couple things going on. One is that, so the Affordable Care Act requires that if you're offering coverage to employees, you need to also offer it to their children, okay? But the Affordable Care Act, the national law, does not require that you cover spouses. That is a Wisconsin state law that requires that you offer it to the spouses. It does not require that you pay anything for it. So because of that rule, Wisconsin insured plans, it relates only to insured plans, cannot do a so-called spousal carve-out. You have to at least offer it. Now, if you are in Wisconsin and you're self-insured, you're exempt from that state law, and you could say, bye-bye spouses if you wanted to. So it depends on if you're insured and it's state-based.
The question is related to eligibility for Medicare patients or non-eligible.
I might not have been listening completely. I do know that as it relates to Medicaid and Badger Care, we're moving some folks off of Badger Care into the federal marketplace. That the whole discussion about the expansion of Medicaid. On the flip side, however, childless adults who are 100% less of the federal poverty level will be moved into Medicaid. and it's almost gonna be a wash in terms of the migration in and out. And I guess maybe someone might have heard it better, but.
She did say that, and I don't know now, she said Medicaid or Medicare. She did say that, though. She definitely did. It's Medicaid, yeah.
Did she say Medicaid? Okay.
So does Patrick here go away as well?
Essentially, it's Medicaid up to 100% of the federal poverty level, and it'll now include childless adults. And then anybody over 100% of the federal poverty level will be moved into the, up to 400% will be eligible for a subsidy in the federal marketplace. That's basically what.
Go ahead.
I'm a broker, and
I think it's, I think instead of it being new, it's just an area where there's been some misunderstanding, and apparently, like the gentleman we were speaking with earlier had been given the wrong information at a couple of seminars, he said, or presentations. So, there may be some different versions floating around out there, but Terry and I both absolutely agree that what the law is in your case, you've got the 7 full-time, so they're 30 or more hours a week on average. And then you've got 200, are they all under 30, would you say?
Most of them, yes.
Most, okay. Okay, so, so what you need to do, you follow the counting rules that the law gives us. You convert your part-timers to a full-time equivalent number, add that to your 7, and check, am I above 50 or not? And in your case, to make it more exciting, it's probably going to vary on a monthly basis. You're going to have to keep on top of it and maybe use a safe harbor method to count it with a look-back period, so you've got a little bit more certainty about what you're doing going forward. But let's.
So you're adding the FTEs, or not the FTEs, but the hours per each person. So if one works 1 day a week, and there's a couple that work 3 days a week, you add all those together to come up with an FTE.
Yes.
So that is still true.
Well, yeah.
Yeah, I mean, there's 2 steps in this whole penalty process.
That was
One,
part
am
one.
I a large employer? You probably are a large employer. Based on 7 full-time equivalents and 2 in temporary, I'm gonna assume that you get up to 50 at least full-time and or full-time equivalents. You are a large employer. The second step is, do I have a penalty?
And that's separate.
Yeah, and you only have a penalty on your full-time people. No equivalent discussion there whatsoever. Your full-time people are 7. Those are the only people that you can have a penalty on. If you do not offer insurance, you only have that penalty on your full-time people, but you get 30 free.
So
it's
equals
two,
no penalty
it's
for
two
you.
separate things. You look at everybody to determine if you're a large employer. So some of you in this room might have also be making some of these same mistakes. Because now it's the second question. You look at everybody to determine whether or not you're a large employer. Once you say, yes, I'm a large employer, now who are my full-time people, my only 30 hours a week or more? Those are the only people I can have a penalty on. So somebody could have 100,000 employees on a full-time equivalency basis, and if not one of them work 30 hours a week or more, there's 0 penalty for them. Walmart.
Or if only 29 do.
Right, 129, yes.
So this is recently clarified?
No, this has been the rule all along.
It's always been.
Yep.
But I think there's some people muddying the waters out there.
Yeah. Yeah.
What did he say?
That guy was happy.
Pay for
That
the
guy was
seminar,
happy
right?
too.
Go ahead.
Well, it's based on household income. So obviously you're not going to ask your employee this because they're going to tell you to take a hike. But you obviously in a small employer situation, you know if your employees are working because if they have group health insurance, you probably know if they have a spouse, you probably know if they have kids. You probably know what that spouse is doing because you might have asked information about what insurance does your spouse have. You probably know about your employees, so you can probably take an educated guess to say what is their household income in terms of wage. You don't know that they're running a side business and they have a ton of income, if they have losses. You don't know if someone's paying alimony. You don't know any of that to determine what their AGI is. You only know wage, and you can make an educated guess about a spouse, potentially. It's not a perfect science, but you could take an educated guess.
Not this year. Employee choice was the portion that was delayed for 2014. 2015, I mean, that's the intent of the shop, that eventually it will be like that. But for this year, you as an employer would make a selection of a particular plan, one plan option, and the employee could enroll online. But in 2015 is when it starts, when as an employer you can go on, you pick a metal level, and then you have all the QHP plans, different carriers that the employee could choose from.
Can we convert, or can they convert that?
Well, Arise is a regional plan. It's not a national network. In a situation when you're traveling outside of our footprint, you're always going to have the coverage for emergency services. All of those type of urgent situations are covered as they would be in network. But as far as someone that lives out of the state for, like in your example, 6 months, we're probably not going to be the best option for you. So it's something you want to. There are some carriers out there, national networks. If you're in that situation, you definitely would want to keep that in mind.
So some of the providers,
Any final comments from the panelists? All right, well, I'd like to thank everybody, thank the panelists, and thank everybody for attending, and good luck as we're all trying to figure this out.